Okay, so 9:05, I think in honor of time, people are still entering, but we will start. So today, mostly the idea was to talk about different pathologies that affect the thumb in trauma, congenital, and also the technique how to reconstruct the thumb. Uh, I think the history of the thumb reconstruction, especially in congenital, is more or less the evolution of hand surgery in the world. So it's very interesting the history of politicization and the thinking and the reconstruction of the thumb. So probably it represents all the evolution of hand surgery. So it's very interesting to know the pathologies and the technique of how to reconstruct the thumb. So we have the honor today of having Scott Kozin, which is a pioneer in this topic, and he will talk us about thumb hypoplasia and how he managed this pathology.
Good morning, everybody. I am going to be the lead up for Jane, who's going to talk about politicization. I was hoping to get politicization because that's my favorite, but Pablo gave me thumb hypoplasia, which is a lead up for Jane and politicization. But I'm basically going to talk about how we approach thumb hypoplasia and what our current practice management is. When I say our current practice, I'm talking about me, Dr. Zlatilo, who many of you know, and then Dr. Park, who's our new addition to our practice, who's primarily focusing on everything but including spasticity. So a couple things. I do think that 10 fingers are overrated. Everybody wants to have 10 fingers. I totally understand. But we can do most, if not everything in life without 10 fingers. So what you need in life, though, you definitely need a thumb, which Jane will talk about. And you need some type of post, the post against to utilize your thumb. So Peter Carter, who is a mentor to many of us, and therefore he's a mentor to many of you because this lineage has been passed down. He is what's known as the 2-4 rule. You want to do something to the patient for the patient. I think it's extremely important when we look at thumb hypoplasia or virtually anything that's our philosophy. The Kozin rule is in life you need a thumb and a post. So our goal is to make a thumb and a post. I think in our current practice, function trumps form, which is another important concept. But you want to make sure that you get a good stout thumb and some fingers to post against. And I think that's important. Now, when we talk about thumb hypoplasia, again, I think thumb reconstruction requires a stable base. It's like trying to build a house without a foundation. For us, if there's an unstable base, we still prefer politicization, which has been far superior to any attempt in our practice to reconstruct the base. But saying that, it's not always easy to tell if there is a base, because ossification of the carpal metacarpal joint doesn't occur somewhere between 4 to 7 years. Now, you can use advanced imaging studies like an MRI, which shows cartilage. You can use an ultrasound, which Paco uses now and then. But I think it's sometimes best just to wait because the child will tell you the answer. And almost all children with a stable CMC joint will incorporate their hypoplastic thumb into function. If the hypoplastic does not have a stable CMC joint, they'll typically bypass and move to the thumb and index. I'm sorry, move to the index and long. So you either can get an advanced imaging study, we just prefer to wait and let the child determine. It also allows extra time for the parents to get used to the concept that thumb may need to be ablated. Once they realize that thumb, even a pouce flottante, isn't being used, they're more comfortable with having it removed. And pulsation is clearly indicated for an absent CMC joint and an unstable CMC joint that Jane will speak about. So for us, a thumb hypoplasia is primarily managed with operative intervention for a type 2 and a type 3A. Type 1 occasionally will require opposition transfer, but usually doesn't require any treatment whatsoever. A type 3B, 4, and 5 are treated with pulsation. We do need to spend a minute speaking about thumb opposition. It's an extremely complicated motion. It requires palmar abduction of the thumb. It requires flexion of the metacarpal phalangeal joint and requires pronation. I think of opposition as if I'm looking down the end of the thumb. It's like an ice cream cone, and the base of that ice cream cone is at the carpal metacarpal joint, and the work of opposition is in the end of the cone. That's how to think of opposition. You can't think of it as simply bringing your thumb over to touch your small finger, because it has to be this arc that requires palmar abduction, metacarpal phalangeal flexion, and some pronation. In terms of thumb hypoplasia procedures, again, we want to address all the deficiencies. And we'll talk about this each individually. You want to address the narrow web, which is really important. You want to address the absence of the thenar muscles, although we can't recreate a situation where we can place all the deficiency in the thenar muscles. And if there's MCP joint instability, that also needs to be addressed. And we can talk about whether it's stable on the UCL or stable on the RCL or stable globally with both UCL and RCL insufficiency. We can talk about both of those. And then pulsation, I'll leave that to Jane. So mild thumb hypoplasia, again, this is a type 2 or 3A. Thenar deficiency, typically UCL instability, but you can see RCL instability. And then a narrow web space. Our web space management typically requires a 4-flap Z-plasty. So a 4-flap Z-plasty will gain about 150% of space, right? And versus a 2-flap Z-plasty. A 2-flap Z-plasty gains about 75%, but leads to a deep V. So we prefer a 4-flap Z-plasty. We want to release the fascia. We want to protect the princeps to make sure that that's not damaged. I'm going to step out 1 second. My pictures are just went away. It's okay. I don't really need them. I don't think I need them. Give me a second here. Sorry about that. In terms of our donors, let me go back a second. I think you have. I'm going to just talk through this because my pictures, for some reason, went away. Everyone talks about whether you can use an Uber type of transfer or whether you can use an FDS. For us, we always use an FDS. I think an FDS is a better transfer to use. I think it's more reliable and it allows for a better reconstruction. We rarely, if ever, use a hypothenar muscle. It just doesn't seem to work. So FDS is our preferred donor. If you look at the basic biomechanics, the abductor digiti mini, or quinti, has a fiber length of only 4 centimeters. And remember, excursion is related to fiber length. FDS has a much longer excursion of 7.3 centimeters, so it makes a better opposition transfer. And then in terms of strength, again, the FDS is stronger than the abductor digiti quinti. Well, give me 1 second. Sorry about this, guys. Everything just blew up. In terms of technique, Pablo, I'm going to step out 1 second. I got to fix this. Give me 1 second.
Yes, no
1
problem.
second. Don't go anywhere. I got to figure out what just happened to my talk. Here we go. Let me come back in here. Sorry about that, guys. There we go. This should work. In terms of excursion that we talked about and mass fraction. In terms of how do we do it, I'm going to run to a case. This is Andrek, a 9-year-old with type 2 thumb hypoplasia. FDS harvest, FCU pulley we're going to use. And we're going to pass the FDS through the pulley. Then we're going to tunnel it all the way over to the thumb. Here we go. So here we go. 9-year-old with type 2 thumb hypoplasia. Here's our technique of FDS harvest. Standard FCU pulley, as you see here. We're going to tunnel the FDS through this tunnel. And then we're going to pass it through the metacarpal head. So the additional length of the FDS can be used to reconstruct the UCL. And then we'll pass it along the UCL. Here's your UCL reconstruction. And then we're going to pin the metacarpal phalangeal joint, and we're going to close our 4-flap Z-plasty. In terms of technique, let's just take our time now that the video is finally working. So this is a different patient with both type 2 or type 3A hypoplasia and MCL instability or UCL instability. Here's our incisions. Here's our four-flap Z-plasty. Four-flap Z-plasty is done first. The princeps is identified, and the respective proper digital arteries are protected. Again, we're going to gain about 150% breath from this Z-plasty. We tend to close the radial three limbs primarily, leaving the most radial limb open to allow for UCL reconstruction at this time. We're going to find the FDS at the base of the ring finger, make sure it's not the FDP. We're going to cut the tendon just at the level of the A1 pulley. You don't need any additional length. Cutting at the A1 pulley is plenty of length. We're going to do our standard FCU loop. So the FCU is split in half, kind of like string cheese, and loop back onto itself. For us, the loop is the correct size when a freer elevator is placed within the loop. And then we're going to suture that tendon back to itself. Don't forget to pass the tendon through the loop and then over to the thumb. We've made a subcutaneous tunnel. We're using a Carroll tendon passer to retrieve the tendon. Here the tendon is retrieved within the thumb. Now, with reference to our reconstruction, we prefer a bone tunnel. So a bone tunnel is passed through the metacarpal head, and then the FDS tendon is passed through this bone tunnel. So that's plenty of length to reconstruct the UCL. At this time, we're going to pin the joint to make sure it's stable and well aligned. We're going to set the tension in our opposition transfer first. You can see how the tendon is bowing across the skin. That's usually the right tension. Then with the additional tendon that's been passed through the bone, we're going to reconstruct the UCL in an extra periosteal type fashion. You don't necessarily open the joint. Sometimes you can pass it one time. Sometimes there's even enough length to pass it back on itself for a double-breasted repair. You put the needle right through the bone. It's a little bit of a push, but just take your time. It'll go right through the bone. And then we're going to tie it down. So you can see this technique allows for both opposition transfer and reconstruction and allows for UCL reconstruction like you see here. We're then going to close this last limb that's been left open. If the tendon sticks out across the skin, that's usually the right tension for opposition transfer. You want to bowstring just a little bit. You want to check your pulley to make sure it's intact and hasn't attenuated, and then you want to get them moving. In terms of how they do, here's a long-term outcome. So there's really good thumb opposition. Again, palmar abduction, MCP joint flexion, and opposition. That's the three elements of true opposition. There's even a little bit of pronation in this thumb, which probably is dependent upon where we attach it to the bone at the level of the metacarpal. And then in terms of outcome with reference to texting, you can see here, which is super important nowadays. It's the left thumb, nice and stable, and then you can text easily, right? Now, if you have involvement of both the UCL and the RCL, you have two choices. You can reconstruct both sides with additional tendon, or you can perform an MCP joint chondrodesis. And I think both are options to manage a globally unstable MCP joint, and we currently prefer chondrodesis over trying to reconstruct both the RCL and the LCL and the UCL. And with that, I will stop for now. Thank you very much. Sorry for the video blip, but we fixed it.
Thank you very much, Dr. Kozin. Very nice talk and very clear of each step. And have you, in all your practice, have you tried other oppositional transfers? What was your experience? Why did you stay with the FDS finally?
Yeah. So we have tried them all, right? That's the benefit of trying to having them practice. We've tried all of them. I used to do the abductor digiprinting. I find that operation fairly difficult. People talk about the muscle bulk of the abductor building up the thenars. In my practice, it always landed across the palm. It never quite made it to the thenar eminence. I think you do have to detach it from its origin to get it to reach if you're going to do the abductor. And I don't think you can use the abductor if you're going to reconstruct the UCL. You need some other tissue. That's number one. The second option, we've done EIP, right? Burkholder technique. A couple tidbits about the EIP. If you're going to use the EIP, you need additional length of the tendon. You have to take a strip of the extensor hood out to the PIP joint. I think that's an important lesson. I think that is harder to learn. You know, a lot of people have really good results with EIP for opposition transfer. We have not had similar results. And I'm talking not just about thumb hypoplasia, but about opposition transfer in global. The one thing that has worked for us, and Paco uses it also, is the ECU works. Right? The ECU can be elongated. It comes across the palm. It has a nice vector, and it's fairly easy for children and adults to relearn. To learn, actually. You do get a little bit of radial deviation from loss of the extensor carpi ulnaris, or we call it the extensor carpi ulnar deviator. And remember, it's not a wrist extensor, it's an ulnar deviator. But that opposition transfer has been worked pretty well, especially in children with a spinal cord injury where it can be present. But at the same time, if I had a list, it would be FDS, 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 followed by all the others. And so it takes a lot for me not to use the FDS. It's become really a part of our mainstay in our practice for reconstruction of opposition. I know Dan and Gina are the same way. Pablo, what is your preferred? I mean, you're.
Yeah, we use FDS also because we think it has the advantage of reconstructing the ligament also. So what is very interesting is that with the pulley, as I saw in your video, when you transfer the tendon, then the pulley goes a little bit more radially. So it goes, my grandfather always told me, opposition has 3 movements. One is from the radial nerve with the abductor, that you do some abduction and retroposition to put the thumb out of the hand. Then it has a medial nerve movement, that is the transfer goes through the FCR tunnel. And then you have the ulnar movement, that is more of a flexion movement. In all that 3 movements, the nail pronates. So if you go more distal and cross the palm, you have more ulnar movement. And I think the FDS is taking more the medial nerve movement of the opposition. I don't know if you think that also.
No, I think your grandfather was probably right. If some of our long-term follow-up of our opposition transfers, if that pulley stretches out a little bit, they end up having more thumb palmar abduction, right? So you see where the tendon migrates a little bit toward the midline, they lose some of the ability to truly, just like your grandfather said, to pronate. So if that pulley migrates, it ends up being a really good palmar abductor, but not nearly as good as an opposition transfer. I discourage people, by the way, from using the distal aspect of the transverse carpal ligament that's been written about. That leads to way too much ulnar nerve stuff. Too much adducts. That's a bad pulley. I mean, Bill Cooney, umpteen years ago, showed us in the lab that any opposition transfer works best when it comes from the pisiform. And so the pisiform is the right vector. So whether you're using ECU or EIP or FDS, I always think I got to get it to the pisiform for the right vector to allow for what your grandfather said: radial nerve, median nerve, and ulnar nerve function. Great point, actually. But keeping it all the way over the pisiform is not always easy, especially in these young males that use it a lot. But we try our best. And then there's a question about what age do we do opposition transfer? We'll do it as soon as whenever we reconstruct the thumb. So it's a bad answer, actually. I apologize. So again, a Peter Carter rule, you know, the 2-4 rule. Peter Carter tells parents, and we tell parents, that the hand doubles in the first 2 years of life in size, and then doesn't double again till you're done growing. Think about that statement. And parents often go, whoa. So the hand has this tremendous growth in the first 2 years of life. So if we can delay an operation to 18 to 24 months, that's our preference. And Jane's going to talk about pollicization. Even for us, we did a pollicization this week, myself and Dan, and the kid was 2, right? And I just think the operation is easier, just like opposition transfer is easier when the hand is bigger. And if the hand's going to double in the first 2 years of life, I am going to wait, if I can, until they're 18 to 24 months. Even for syndactyly between the long and ring finger, we wait to 18 to 24 months. So I think it's a really valid point to tell parents, and I think your surgical stress will be less because everything will be bigger.
Wow, good. Thank you very much. Dr. Kozin, I wanted to ask you, when you do the transfer, and I saw the bowstring. You do it subcutaneous. Do you think it can have a mechanical advantage to go under the thinner fascia?
Yeah. So it's a great question. I think it can have a mechanical advantage to go deep to the muscles. So in those kids with example Charcot-Marie tooth, that initially had muscles, you can clearly tunnel under the muscles. Obviously, in thumb hypoplasia, there never were any muscles, so you're stuck with putting it subcutaneous. Pablo, there's also a really good question in the chat, which I did not mention, which I should have mentioned. The question was, have you ever encountered any swan neck cases from FDS harness? The answer is yes, but let me tell you how to avoid it, right? If you examine the donor finger, and the donor finger is very lax, so you have the ability to manipulate them into swan neck. Does that make sense? Right? Pre-op. This is before surgery. Right?
Passively.
If you then do the surgery and you put them in a silver ring splint, right, post-operatively, and then that tail that you left will scar down and act like a volar restraint, then they won't swan neck. It's a great point. It's actually the opposite. If you operate on a lot of adults, which I don't do anymore, but these big burly men who are prone to PIP joint contractures, if you harvest their FDS, they end up with a PIP flexion contracture. If you prophylactically splint them postoperatively with a dorsal extension splint for a few weeks, it'll avoid that. So we should look for swan neck pre-op passively, and we should be careful of the burly man who's developing a PIP contracture. But a little silver ring around the ring finger, a long finger, wherever you harvest the FDS, will save you a lot of angst. Good question.
Thank you very much. Just to ask you, in the pre-op, like in radial deficiencies, do you rule out any comorbidities in these, any other pathologies, kidneys, gastrointestinal problems?
So, Pablo, it's a very important point. I think our responsibility is to work up radial deficiency children, right? So again, I saw a kid this week who had bilateral radial deficiency. Fortunately or unfortunately, he had the kidneys worked up. He had the heart worked up. He was worked up for TAR, right? But what he wasn't worked up for was Fanconi anemia. So he had not had a chromosomal challenge test. So what we do in the States now, since EMRs are readily available to parents, I say to them, all right, I am going to dictate in your note that you need to get a chromosomal challenge test. You should go onto the portal, you should take that note, and you should show it to your pediatrician to make sure that that test gets done. Because even though it's rare, we need to make the diagnosis early. So I don't think we can absolve ourselves of that responsibility. I don't think that should be the parents or the pediatrician. We're the ones that see these kids. One more really important point is that if you have a child with Fanconi anemia, they look very typical to a VACTERL child, right? So, I mean, there are things, cafe au lait spots and other things, but don't get fooled with a child that presents to your office with a known diagnosis of VACTERL association who has not had a workup for Fanconi anemia. And you assume the diagnosis of VACTERL association, which could be the false assumption. So again, we need to make sure that everything is worked up according to what we know that develops at the same time in utero, including Fanconi anemia.
Thank you very much. Thank you. So any other question in the chat here? Not really. From the panel, any other questions to Dr. Kozin? So, Andres, do you think we continue with Dr. Jane Shen talk?
Yes, great. We'll put her as a co-host. So,
just the last question to Dr. Kozin. Oh, okay. Yes, I do. He uses K-wire. Thank you.